very warm good morning to our respected teachers and my dear friends, and especially thanks to our the PBL coordinators for Professor Dr. Bijay and Dr. Baral and our resource faculty Dr. Raman Prasad Kushwaha sir and our tutor Dr. Akshat sir. Myself, Mohammad Ayub presenting on behalf of my group on a topic of brief account of the anti-epileptic drugs, its mechanism of action and the choice of the drugs for the epileptic patients here. So let's get started. These are our objectives which we are covering today here. So first we have to understand what is a seizure. The seizure is actually the focal paroxysmal abnormal discharge at a high frequency in the cerebral cortex that manifests as either the loss or the disturbance of the consciousness and that leads to either sensory motor or the psychomotor experiences to the patient here. Then along with the seizure always the term epilepsy comes here. So we have to identify what is epilepsy and what is seizure here. So what is the epilepsy means characterized is a medical condition that is characterized by the recurrent episodes of the seizure which is actually not provoked by any systemic or the acute neurological insult. So we have to understand here that every seizure is not an epilepsy. So next we have classified the seizure is classified as International League Against the Epilepsy 2017 has classified the seizure on the based on the onset here. So it is classified as a focal onset and generalized onset here. Again the focal onset is classified based on this loss of consciousness or the intact consciousness of the patient, that is simple partial seizure and the complex partial seizure and the partial seizure secondary generalized here. So again the generalized seizure has classified as the motor seizure and the non-motor seizure. In non-motor seizure it includes the absence seizure here and the motor seizure includes like generalized tonic-clonic seizure, myoclonic seizure, atonic seizure like that. So now we enter into the pharmacology of the anti-epileptic drugs here. So for that we have the anti-epileptic drugs as classified as like this based on the molecular structure. It is classified as a group like the barbiturates here, deoxybarbiturates, and then after some benzodiazepines here, then cyclic GABA analogs here like that, and some newer drugs have been also found like topiramate, levetiracetam like that here. Now we have to we enter the mechanism of action. Before understanding the mechanism of action of the anti-epileptic drugs, we have to understand the physiology and its pathology for originating the seizure. So in the physiology, like in normal physiology, when the stimulus comes to downward in the presynaptic neurons here, it will stimulate the sodium channel, and the entry of the sodium channel will occur. That and accumulation of the positive charge in the presynaptic neuron that will lead to increase the depolarization and ultimately increase the action potential. This action potential comes to this again stimulate the calcium channel which will be in the presynaptic membrane here, and this entry of the calcium channel will occur. Now this calcium channel loves to stimulate the vesicles to fuse with this presynaptic membrane, and this release of the glutamate neurotransmitter will occur in the synaptic cleft that will act on its receptor, NMDA receptor and AMPA receptor on the postsynaptic neuron. And again, this is actually the excitatory pathway. Again, in our body there is an inhibitory pathway also, like the GABAergic pathway. Like in the GABAergic pathway, in the GABA neurotransmitter is the inhibitory neurotransmitter which will release in the synaptic cleft in the same way as the glutamate released in the synaptic cleft here. So what this GABA neurotransmitter will act on its receptor, GABA-A receptor on the postsynaptic membrane, and this will lead to the opening of the chloride channel and the entry of the chloride channel that will lead to the hyperpolarization, and it will balance this over-excitation of the glutaminergic excitatory event in the postsynaptic neurons. In this way, in our normal physiology, this excitatory pathway and the glutaminergic pathway both are in the balanced way. But in the seizure patient, what happened is that any underlying cause, this excitatory pathway will be increased and the inhibitory pathway will be decreased here. Actually, in the seizure patient, this GABA receptor will be dysfunction here, so inhibitory pathway will not able to inhibit the excitation of the excitatory pathway here. So there will occur the overexcitation of the neurons here that will ultimately lead to the seizure. So by understanding this pathophysiology, we can now enter into the mechanism of action. Like first of all, if we give any drug, that will block either these channels so that it will decrease the excitatory pathway, or it will increase the activity of the inhibitory pathway that will help to control the seizure here. So that we can use the sodium channel blocker here, like sodium channel blocker like the phenytoin, carbamazepine, lamotrigine and the topiramate like that drug here, that will block actually this sodium channel. So even the stimulus will come here, this sodium channel will not be able to open, so sodium will not enter into the presynaptic neuron. So ultimately, the glutamate release will be blocked here, and the excitatory pathway will be blocked. Like that, there will be the SB2A synaptic protein. This SB2A synaptic protein will be on the surface of the vesicles here. So that will help to fusion of the vesicle with the presynaptic membrane. But if we block this SB2A synaptic protein, like by the drug levotriacetam system or the system, this vesicle will not able to fuse with the presynaptic membrane, and ultimately glutamate will be blocked here. In the same way, ethosuximide here. Like ethosuximide is a T-type calcium channel blocker. Like if it is the T-type calcium channel blocker, is actually the low voltage gated calcium channel blocker, which will in the postsynaptic membrane here. So like if this glutamate will act on this receptor NMD and AMP receptors, this lots of sodium channel, and magnesium channel and calcium channel will open in the postsynaptic neuron membrane, so that the entry of the positive charge will occur. But if we block this calcium channel also here, there will be the decrease the depolarization and decrease action potential for the seizure activity, so that we can control this seizure activity by also the ethosuximide here. Next will be the reticabine. With reticabine, actually the potassium channel opener here. So in normal physiology, what happens is that this potassium channel will be closed in the presynaptic membrane or the postsynaptic membrane here. But if we use this reticabine, this open the potassium channel in the presynaptic and the postsynaptic membrane both here, and ultimately there will be the release out of the potassium from the inside the cell to the outside the cell. That will lead to the repolarization, and that will decrease the depolarization and the decrease the action potential, and the same way decrease the excitability. In the same way, there will be the two receptors, the AMPA receptor and the NMDA receptors, on which this glutamate excitatory neurotransmitter will act. So if we block this neurotransmitter from this glutamate will not able to act on this receptor, and ultimately this opening of this positive charge channels will be blocked here, and again depolarization will be blocked here. So this NMDA receptor will be like the drug felbamate that will block the NMDA receptor, and this AMP receptor, that is parent panel, that will block the AMPA receptors here. In the same way now, this is all about excitatory neurons where we use this drug. Now in the GABAergic neurons, what happens is that in the GABAergic neuron, GABA neurotransmitter will act on this receptor, GABA A receptor here. So in the seizure patient, this GABA A receptor will be normally dysfunction. So if we give any drug that will either analogs to the GABA receptor, means more amount of GABA will be in the synaptic cleft here. So it stimulates the receptor to respond to the GABA neurotransmitter that will be in the synaptic cleft here. So in that drug we have the type of drug benzodiazepines and the barbiturates here. These both act on this GABA receptor, but its action will be also different here. Like benzodiazepines act on this on one side of this receptor, that will actually increase the frequency of this chloride channel to the GABA receptors here, so that more amount of GABA in the synaptic cleft will enter into the presynaptic membrane, postsynaptic membrane here, and ultimately the inhibitory action will occur here. The same with these barbiturates also act on the receptor, but on a different receptor on this GABA receptor. Like in the GABA receptor there will be the 2 alpha beta like that receptor site here. So these barbiturates act on that here, and it will actually prolong the opening of chloride channel on this GABA receptor, so that more the chloride channel will be open for the long duration of time, and more amount of GABA can act on this receptor, and this chloride channel will enter into postsynaptic membrane, and it will affect the inhibitory effect will show here. The same way, so normally this GABA will act on its receptor and physiologically, and it will detach from the receptor and again reuptake into its presynaptic neuron here. So this GABA, if we block this reuptake into the presynaptic neuron, that will then more amount of GABA neurotransmitter will be in the synaptic cleft here, and again it more stimulate its receptor, and the entry of the chloride channel will be increased. In the same way, so if this is a tiagabine drug that will actually block this transporter that will reuptake in the GABA into the presynaptic neuron, that will be called GABA transporter. So tiagabine is actually the GABA transporter that will block this entry of this GABA again into the presynaptic neuron, and more amount of GABA neurotransmitter will be there in the synaptic cleft here. In the same way, there will be one. I already said there is a calcium channel, but this in the presynaptic is a high voltage calcium channel here. So it is also blocked by there is a sub unit on the calcium channel alpha to delta sub unit. So it is actually what does, if we block this top unit from any drug, then again the entry of the calcium will block in the presynaptic neuron and it will lead to the decrease of depolarization, decrease the action potential. So this drug will be the gabapentin and pregabalin, that will actually block this alpha to delta subunit of the calcium channel here, that will decrease the excitatory pathway again. So again there is a retigabalin, as already described, the retigabalin is potassium channel opener both in the both presynaptic neuron as well as in the postsynaptic neuron. In this way we can control by blocking and by increasing this neurotransmitter pathway, we can control the seizures. So this is all about the mechanism of action of the anti-epileptic drugs here. So next, another one thing is that when this GABA enter into presynaptic neuron, it will become inactivated by converting into the succinate semialdehyde into this GABA into succinate semialdehyde by the one enzyme, that is the GABA transaminase here. So if we use any drug that will block that enzyme GABA transaminase here, then again this GABA from the presynaptic neuron will incorporate into the vesicles, and this vesicle will be, and the GABA will be released into synaptic cleft and it will act on its receptor here. So that enzyme inhibitor is the vegapentin, that will block this enzyme GABA transaminase here, and the inhibitory pathway will occur again. Now that we intend to drug of choice for the patient, drug of choice for the patient here. Actually, the drug of choice for the patient depends on the type of the seizure the patient has here and the clinical manifestation the patient shows. So based on this, we have the partial seizure. The partial seizure means the first line drug will be the carbamazepine or the lamotrigine like that drug, and there will also alternative drug and the reserve drug. Means if we give the first, our choice will be the first line drug. But if the first line drug, even the therapeutic dose, it will not respond to the seizure, we can receive the alternative drug like levetiracetam here, and known as the reserve drug. But even if the alternative drug will not respond, then that will be the case of the refractory status epilepticus, and we have to use the combination of the drug here. For that, we can use this the first line drug with the reserve drug or alternative drug with the reserve drug. But we cannot combine this first line drug with the alternative drug here. Again, like that, for generalized tonic-clonic seizure, there will be the valproate will be the lamotrigine the first line drug here, and in absence of the valproate and ethosuximide here. Here we have to consider that is previously for the absence seizure ethosuximide is used here, but nowadays valproate is most commonly used in the absence seizure here, and for myoclonic again the absence valproate will be used here. In atonic valproate is used, and in the febrile seizure means seizure in the child during the fever, we can use the diazepam which is given rectally here. And for the status epilepticus, we have the first choice of drug for the initially will be the benzodiazepine drug, that will be the lorazepam or the diazepam here. Similarly, now our main motto of the drug is to control the seizure and with the minimum toxicity here. So we also have to consider the side effect of this anti-epileptic drugs here, because the anti-epileptic drugs are the more large overwhelmed side effects. So we have to consider is also here. So like if phenytoin is given here. Most common will be the acute phenytoin toxicity to the passenger, that includes either gum hypoplasia, this hirsutism or the facial portioning, like that symptoms. So we have to consider it, and also the neurological symptom is ataxia, sedation, confusion, also dizziness also. And we see that in side effect, we see that most of the side effect, neurological side effect will be common here. So if any drug that will affect our cerebellum also, that will lead to the ataxia. And if with that drug also affect our reticular formation, that will lead to the sedation most commonly. So in most of the drug we see the ataxia and sedation will be common here. Similarly, there is a carbamazepine drug. Like carbamazepine drug, again the ataxia, diplopia, vertigo will be our side effect here. And again, carbamazepine aplastic anemia, the most important side effect will be the aplastic anemia, hepatotoxicity, like that. So we have to consider it. And also for hepatotoxicity, we have to continuously use this drug for the liver disease patients here. Similarly, for valproic acid, it is the most broad spectrum anti-epileptic drugs here, but it's the most important side effect we have to consider is teratogenicity here. So it should be avoided in the case of the pregnancy, that will lead to the neural tube defect also. And against this other side effect like hepatotoxicity, like that, ataxia, sedation, like this. Next one is our lamotrigine. Lamotrigine is the drug of choice, but it's also one important side effect with the skin rashes, and another is the Stevens-Johnson syndrome here, that will lead to the outcome of the immunological reaction. So we have to consider it. And lamotrigine, again, there is a side effect of ataxia, sedation, and diplopia. And here we have seen that the drug interaction. So if we are using two or more drug, we have to think about the interaction also here. Similarly, ethosuximide here is adverse effect in bone marrow suppression is seen as here is the most important side effect to be like the bone marrow suppression here. So we have to, before starting the ethosuximide here, we have to assess the CBC of the patient for the baseline. And again, after starting this ethosuximide here, we have to again assess so that we can manage the side effect of this drug here. Again, lethargy and ataxia with another side effect. And gabapentin also is the side effect edema, weight gain, gastrointestinal and like sedation, dizziness, but its interaction will be there. In other drugs there will be lots of interaction with the other drugs here, but in the gabapentin the interaction is minimal, so it can be used here. Next one is the conditions for epilepsy in the pregnancy and the children here. Like the epilepsy in the pregnancy will condition when woman is on the anti-epileptic therapy here and is conceived here, then we should not have to stop the drug because withdrawal of the drug leads to the status epilepticus case here. So we should not have to stop the drug here, and we have to immediately start the folic acid 4 mg must start here. Next one is when any woman who is planning to become the pregnant, then we have to first stabilize this woman with a single anti-epileptic drug here to minimize the side effect, and we have to immediately start this anti-epileptic therapy, and also can be given the folic acid also here. And we can again in the pregnant epilepsy on the pregnancy when the woman is pregnant, if the phenytoin is a treatment of choice of drug, then and we cannot withdraw the drug, so we can give the vitamin K during the labor and up to the baby after the delivery, because this vitamin K, it will cause the deficiency of the vitamin K here, that will cause the hemorrhagic disorder in the baby and the patient also here. So we have to consider it here. And frequently in the interval we have to do the ultrasound for the assessment of any fetal malformation to the baby. Next one is if any patient during the labor and during the labor it will lead to hypertension, that will condition the eclampsia, that will also trigger the seizure. In that case we can give the magnesium sulfate with our drug of choice for in that condition. So now the epilepsy in the children, febrile convulsion is convulsion in the children during the fever, most commonly in the children less than the 5 years here. So for that there in the children this febrile convulsion most important common we have seen the triggering factor is the temperature here, because high temperature will irritate the neurons in the brain, that will lead to the seizure. So we have to maintain the temperature, so we can use either paracetamol here and external cooling method we can use here. Next after we have to start the anti-epileptic drug, like the most drug of choice will be the rectal diazepam 0.5 mg per kg, which can given rectally on the onset of the convulsion here. And if generally the seizure will stop in the 5 minutes, but if the seizure even continues for greater than the 5 minutes, then another dose of this diazepam can be given here, and this dose will be 4 times dose given in the 12 hours. Next will be the case of the status epilepticus here. So what is it? It is actually the medical emergency condition that is actually characterized the recurrent attack of the tonic-clonic seizures, and without recovery of the consciousness in between or last longer than the 30 minutes here. This will be actually the older concept, because nowadays it is considered the greater if the recurrent episode seizure will occur for greater than equal to 5 minutes, it will be considered the status epilepticus here. So it is a very emergency condition, because it will lead to the cardiopulmonary complication here, and abnormal this activity will cause the brain damage also here. So we have to treat immediately. For that first algorithm we have to hospitalize the patients here. Then we have to at least 2 IV to the patients here. Then we have to administer oxygen and we have to collect the blood for the glucose, urea and the electrolytes here. And at the last we have to maintain the electrolyte and the fluid balance here. Then after we start the anti-epileptic therapy here, like first we have the drug choice for the lorazepam, benzodiazepine drug, lorazepam or diazepam here. So we can use this drug first prefer with the lorazepam here. Then again we have to watch for the hypertension and respiratory depression. Again, if this drug will not respond to the seizure, we can repeat the dose again after the 10 minutes here. And if will not respond again, we can give the phosphophenytoin or phenytoin here. Here our choice of drug is the phosphophenytoin, because its duration because phenytoin leads to the vascular complication than the phosphophenytoin here. And we have to monitor the cardiac rhythm and the blood pressure, because it will lead to the either hypertension and arrhythmia also here. So if the seizure continues, it will not respond, then we can use the drug phenobarbital 10 to 50 mg per kg at the rate of 100 mg per minute here, and we have to watch for the respiratory depression. Then again seizure will not continue, it will not control here, it will issue the case of the refractory status epilepticus here, and we have to shift the patient to the ICU here, and we have to start immediately general anesthesia with the midazolam or the propofol at the rate of the 100 milligram per minute here. Here our drug of choice now, we have to propofol, we can use the propofol also because it will act immediately to the patient here, that will help to control the seizure, and again we have to maintain the airway and the blood pressure here. So these are our references here, and if we have any query, we consider it at the end of the session. Thank you for our wonderful attendance.